So now we're going to talk about ectopic pregnancy. I'm sure you guys have just heard about this term because it seems like someone that you've known or someone that someone else has known or has had an ectopic pregnancy before. And ectopic pregnancies are one of the most emergent diagnoses made with sonography. Is a pregnancy located outside the central or fundal location of the uterus. Approximately 10% of maternal deaths are related to ectopic pregnancies. And for a long time, ectopic pregnancies really just made me nervous because when you call it an ectopic pregnancy, most of the time something um, happens pretty fast. Like they either take them to surgery, they start them on medication to stop the pregnancy pretty fast after you have made the diagnosis. The other thing that always made me worried is what if I miss something? And that was a constant fear of mine for the first 5 years, like of scanning, because I just wasn't confident in what if I'm going to see what I'm going to, you know, am I going to see what the right thing? So it takes some time, but I feel like as you become more confident as a sonographer, you really do start to be able to pick it out faster. And now I am really definitely pretty confident that I'm not going to miss anything because I know how to scan through the uterus and the adnexal areas to make sure that I'm not missing anything. So the associated risk factors is a rise in incidence of pelvic infections, use of IUDs, infertility treatments, fallopian tube surgeries, and a history of ectopic pregnancy all give you an extra risk for having an ectopic pregnancy. Clinical findings are pain, non-specific and may vary. Classical clinical findings are vaginal bleeding, empty uterus, presence of adnexal mass, and positive pregnancy tests. From my personal experience, it seems like my normal clinical findings is pain on one side or the other and vaginal bleeding. Then the patient presents supposed to be like 6-7 weeks gestation, has an empty uterus, maybe just a small little itty bitty pseudo gestational sac. And then you look on the right and left adnexa and you definitely see a mass located next to the ovary, and it's pretty easy to diagnose from there. They occur mostly in the fallopian tube, about 95% of the cases. Other sites such as the ovary, broad ligament, peritoneum, cervix, cornua account for the remaining of cases. When an ectopic pregnancy is found in the interstitial portion of the fallopian tube near the uterine cornea, it is an increased risk for massive hemorrhage with rupture that may lead to hysterectomy or even death. And the reason why is because the uterus is so vascular. So those seem to be the most concerning ones. So the tubal is really where a patient mostly has the ectopic pregnancy. This is the interstitial. That's very concerning. That's the one that's really scary. Sometimes you could potentially have it in the cervix or on the ovary. Even in the peritoneum sometimes occurs, but most of the time it's a tubal pregnancy. The beta subunit of HCG quantified from maternal blood by two preparations, first IRP, 2IS. These are two different standards for measuring HCG levels. So it kind of depends on what lab you use. I would say we usually use 2IS, and an IUP is usually at 1,000 HCG. When the patient has reached 1,000 HCG in their blood, it seems that you should be able to see gestational sac. So if you get an HCG level of 3,000 or 5,000 and there's not a gestational sac, then you start getting kind of concerned that there could be something else going on. If discriminatory levels of beta HCG met or surpassed and no IUP is seen, ectopic pregnancy should be suspected. Ectopic pregnancies, you need to know this, and does not produce HCG at normal levels. The normal HCG levels double every 2 days. the HCG levels rise slower with ectopic pregnancies. They may have a similar appearance of an early IUP. In non-emergent cases, serial beta HCG levels are preferred because trending of levels would demonstrate continuing pregnancy if HCG levels rise normally. Falling HCG levels may indicate missed or incomplete abortion. So sometimes what they do if a patient is like 5 weeks and we don't see anything in the gestational sac, they will go ahead and get blood drawn too, and they will get a baseline HCG, and then they will repeat that every couple of days to see if it's rising appropriately. If it's rising appropriately, they might do an ultrasound within another 2 weeks. If it's rising slower, they'll still probably do an ultrasound within a week or two just to see what's going on. If it's going down, that's more cause for concern that it could be a miscarriage. So this is a little chart of showing like how the HCG rises in gestational age. So if you can see normal, the dark line here, it goes up, 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 and then it peaks around 8 to 8 weeks, 8 to 9, and then it drops and kind of stays consistent. This is fetal death, the little dotted line here. It goes up, 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 and then around 4 weeks and it goes down. This dash sign right here, this is an ectopic pregnancy. So you can see it just doesn't rise as fast. So it's a slower rise. And then with a hydatiform mole, it rises pretty fast and then surpasses the normal and then stays up. Here's some pictures of ectopic pregnancy. So this patient comes in, we see first thing you're going to do, you're going to scan having some vaginal bleeding, let's say 6-week gestation, having some pain on her right side. So you scan in the uterus and you see a small gestational sac. But what looks wrong with that gestational sac? It does not look circular, right? It looks more triangular, doesn't have really a double decidual reaction around it, just looks more irregular. So that's cause concern. You're like, okay, that's interesting. So then I also see right here, I see some free fluid. That's a little concerning to me. And then I'm going to go check out and I'm going to see the ovaries. So then I go to the right side and I look and I see the right ovary here with a cyst within it. You see that? Probably a corpus luteum cyst. But then I see a mass right next to it. And that's usually what's going to happen. You're not going to see the ectopic pregnancy on the ovary. You're going to see it adjacent to it. And that's within the fallopian tube. And that's sometimes what an ectopic pregnancy looks like. And it kind of looks like a little yolk sac and a fetal pole right here. So this might be a live IUP or live XUP. Definitely not an IUP. It's not intrauterine. It's extrauterine. It's an ectopic. And there you go. This is kind of what it looks like when you can see a gestational sac. Sometimes there are not gestational sac or yolk sacs, and it's going to look just like a mass. And that's probably from bleeding and hemorrhage. So if you do just see a solid mass, that could be an ectopic too. This one had a heart rate. If you do see a heart rate, you definitely want to document it. So pseudogestational sacs do not contain either living embryo or yolk sac. The pseudogestational sacs are centrally located within the endometrial cavity, unlike burrowed gestational sacs, which is eccentrically placed. Homogeneous level echoes commonly observed in pseudogestational sacs. And the present yolk sac positively indicates an IUP. So if you see a yolk sac, you know that there is an intrauterine pregnancy. If you don't see yolk sac, but you see what we saw here, it's a higher chance that it's a pseudogestational sac. Examining the adnexus sonographically is critical in the evaluation of ectopic pregnancy, and identification of live embryo within adnexus most specific for ectopic gestation. Only approximately 10% of live ectopic pregnancies identified using transabdominal. I really don't even care to do transabdominal ultrasounds on ectopic pregnancies. I much more prefer to do transvaginal because I feel like you you can see so much better. So I almost always do transvaginal ultrasound. So this patient comes in a little scenario here. She is, let's say, 7 weeks gestation and having pain on the right adnexa. So we scan the uterus here and we see free fluid in the posterior cul-de-sac. Not much in the endometrium, which we should be at this time be seeing a gestational sac and yolk sac. And then we go to the right adnexa and we see free fluid within the right adnexa. And that's just kind of not a good sign. Identification of extrauterine sac within the adnexa, one of the most frequent findings of ectopic pregnancy. Extrauterine gestational sacs often demonstrate thickened echogenic ring separate from ovary, which represents trophoblastic tissue or chorionic villi. Possibility that embryo yolk sac will be seen just like this. You're going to have this thickened donut sign is what I say, and that's the trophoblastic tissue. And then you're going to have sometimes the gestational sac, the yolk sac, and the embryo. Color imaging and Doppler waveforms may also be helpful. Risk of ectopic pregnancy can be greater than 90% when intrauterine gestation absent and there is a corresponding adnexal mass. So that's a pretty high. If you don't see an IUP at the time of 6 weeks, but you see an adnexal mass, you have about a 90% chance that that's an ectopic pregnancy. Complex adnexal mass, aside from extrauterine gestational sac, often represent hematoma within the peritoneal cavity. This is just another picture of the endometrium here, and then the right adnexa. There is a mass next to it, and that would be the ectopic. Studies have correlated increased risk of ectopic pregnancy with moderate to large quantities of free fluid and associated adnexal mass. So when you're seeing like a lot of free fluid, like I showed you in a couple images back, where there's some free fluid in the posterior adnexa and there's also some on the right or left adnexa, that just gives me like a feeling that there's something going on. There's usually not that much free fluid without some kind of thing going on. 92% risk of ectopic pregnancy with echogenic free fluid reported, with 50% of cases demonstrating echogenic free fluid as only sonographic finding. When fluid present, sonographers should look at the abdominal gutters and right and left upper quadrants to evaluate for extent and volume of fluid present. So looking up in the Morrison's pouch between the liver and the right kidney is important. So just another thing. So we see in the ectopic pregnancy a pseudo gestational sac with a little sac right there, but no yolk sac, no embryo, nothing, just a plain black thing, black circle. Then we look in the adnexal area and we see transversely, we see the left ovary transverse, and then right next to it, a donut sign with a yolk sac that is a definite ectopic. Then we do the heart rate on the fetal pole that we see within the ectopic, and it shows a heart rate of 179, just example. Then we're looking at the fluid or the uterus, and then in the posterior cul-de-sac, we see a large amount of fluid. That's scary. So if you see that much fluid, then you're going to go look at the liver and the right kidney, and you're going to look for free fluid within the Morrison's pouch too. In that case, with that much free fluid, I think that they would probably take them to surgery because there could be a chance of rupture. So besides just a fallopian tube pregnancy, you can also have an interstitial pregnancy, which is the worst prognosis in ectopic pregnancy. So you'll need to know that. It's also called a corneal pregnancy. And it's potentially most life-threatening of all ectopic gestations. And it's the location of the ectopic pregnancy that's in the segment of fallopian tube that enters the uterus. The site involves periuterine and myometrial vasculature, creating life-threatening hemorrhage when rupture occurs. Interstitial pregnancies have been reported to occur in approximately 2% of all ectopic pregnancies, so it's pretty rare, but it's life-threatening when it does happen. Sonographic identification of interstitial ectopic pregnancy is difficult, described as eccentrically placed gestational sac within the uterus, incomplete myometrial mantle surrounding the sac. And this is what it looks like. So this is a coronal view of the uterus. So if the uterus is up and down and we cut it straight in half, this is the endometrial cavity, the nice cavity here. And then you're going to see your little gestation, or your, it almost looks like a donut sign again, but this is the trophoblastic tissue, and this is the gestational sac. You can see it's on the very, very edge of the uterus, and this would be an interstitial pregnancy. This is a 3D image. This is just a regular 2D image transvaginally, and you can see that the ectopic pregnancy is just on the very edge of the uterus here. And there's not much myometrium in between that and the gestational sac. I think less than 2 millimeters is what constitutes an interstitial pregnancy. You can also have a cervical pregnancy. Cervical ectopic pregnancies have an increased risk of complete hysterectomy because of uncontrollable bleeding caused by the increased vascularity of the cervix. And this is a picture of the endometrial stripe right here. And then within the cervix, you can see a baby implanted. This is a cervical pregnancy. The difference between that and an impending abortion, which sometimes you'll see, is that you will see the decidual reaction. So you'll see that donut sign, the ring around, and then you'll see a nice circular sac. Diagnosis of the embryonic abnormalities in the first trimester. The maximum thickness of the subcutaneous lucency at the back of the neck in embryo at 11 to 14 weeks is called the nuchal translucency. So now we're moving past a little bit. Let's say, okay, a baby is implanted in the uterus now. There's an intrauterine pregnancy. Now a patient wants to get checked, do a nuchal translucency scan to check to see what the risk of a chromosomal abnormality is for the baby. So we'll do what is called a nuchal translucency exam. And what we're looking at is this little area in the back of the neck here. And we measure it, and we want it less than 3 millimeters. And this occurs between 11 weeks and 13 weeks, 6 days is when we can do this exam. This is enlarged. It's 4.44. And look at that. That is abnormal. These babies that have an increased nuchal thickening have increased risk for some chromosome abnormalities and some heart conditions. The increased NT may be found with trisomy 13, 18, and 21 fetuses with cardiac defects and other genetic syndromes. High-resolution transducers have lowered the threshold of when we are able to visualize these anomalies sonographically. NT measurement combined with biochemical markers, free beta HCG, gonadotropin, and pregnancy-associated plasma protein to assess risk for aneuploidy. So a patient will come in within these weeks and they will get the ultrasound scan, and then they will go to lab. You will write on your sheet, you will write how thick the nuchal translucency is, if you can see the nasal bone, and how big the baby is. And then you'll give that sheet to the patient, and the patient will take it to their lab. And then the lab will draw blood, and then they will combine all of the risk analysis and then give the patient like a odds of them having a certain trisomy. A lot of the times I did this with my first child, Quinn, and I got it back and it said less than 1 in 10,000 of her having any trisomies. Fetuses must be between 11 weeks and 13 weeks, 6 days. The crown rump length must be between 45 and 84 millimeters, and the sonographer must obtain optimal images in the mid-sagittal plane. When they say mid-sagittal plane, they want to see the baby like in a straight sagittal, either up or down. The embryo must be away from the amniotic membrane with head in neutral position, no hyperextension or flexion. So sometimes they can be a little bit difficult because that's a lot for you to have to do in a baby that you can't really control. Further research by FMF has established that we can evaluate first trimester fetuses for nuchal thickening, presence or absence of nasal bone, tricuspid regurgitation, abnormal flow in the ductus venosus, and possible abnormalities in the hindbrain. At our clinic, we just do nuchal thickening and nasal bone, but I know at some places they do look at the heart for tricuspid regurgitation and a ductus venosus abnormal flow in the first trimester, but we don't do that at our facility. It just depends on where you are. So cardiac anomalies, yes, we can see some cardiac anomalies in the first trimester. The 4-chamber review and the great vessels are seen as early as 12 weeks. Serial exams to confirm suspected findings. If a patient has an increased nuchal translucency, there is a chance that they could potentially have a heart defect. Ectopic cordis or limb body wall complex are also parts of heart defects. Now, ectopic cordis, ectopia cordis is when the heart is outside the chest. Limb body wall complex is where the fetus is connected to the amnion. So the fetus appears just malformed. Those are things that we can see in the first trimester. You can also see cranial anomalies. We're not going to talk too much about this because we'll talk about it in depth in a couple of weeks. But one of the major ones, there's a couple of things I want to talk to you about. First is rhombocephalin is a normal finding in the hindbrain in a fetus. So if you see a cystic area in the head, that is normal. Acrania or anencephaly, we can diagnose early on in the first trimester. So this is where the baby doesn't have a cranium. So you're going to see brain. This is acrania, but no skull. So this is a normal baby here with a normal forehead and skull and brain with intact. You can see this is anencephaly. Anencephaly is where there's no basically brain or skull. And you can see that there's not the forehead and the skull. It just kind of just goes down. And we'll talk about that more in your next couple chapters. So anencephaly is the congenital absence of brain and cranial vault, and it is the most common neural tube defect, more common than spina bifida. It's still very abnormal, and we don't see it very often, but when we do, it's really easy to diagnose. You can also have abdominal wall defects that we can see within the first trimester. You are going to have normal midgut herniation, 9 to 11 weeks, that's normal. And that's just a little bit where some of the gut comes out because the baby needs to get a little bit bigger before it can go back in and everything can adjust. This is a larger wall defect that looks like part of the liver. And when we see the liver in that large area like that, we're thinking more of an omphalocele, which we'll talk about more in your abdominal wall defect chapter. Just kind of telling you we can diagnose some stuff in first trimester, but you don't get too much into it. Cystic hygroma, that is one thing that I do want you to know for this chapter. It's one of the most common abnormalities seen in the first trimester. Cystic hygromas are seen in early fetal life, have a high association with the chromosome abnormality, and most common trisomy is 13, 18, 21. And what you're going to see, this is a transverse of the head, and in the back of the neck, you're going to see all this lymphatic drainage. Basically is what a cystic hygroma is. It's just fluid and septations. In fetus is detected with cystic hygroma in second and third trimesters, Turner syndrome, which is 1X is most common karyotype abnormality. If hygroma resolves by 18 weeks and fetus has normal targeted ultrasound at 20 to 22 weeks without anomalies, then perinatal risk not statistically increased. So the cystic hygroma is visualized in the first trimester, may vary in size, but all appear on the posterior aspect of the fetal neck and upper thorax. And soft tissue thickening may also be present and should be considered nuchal thickening. So this is just also nuchal thickness, but that's more of a cystic hygroma because it is just so thick. Cystic hygroma and nuchal thickening may be concordant and differentiate may be difficult. Any posterior neck thickness of greater than 3 millimeters with or without septation should be followed. So it's abnormal either way. If a baby has a thickened nuchal translucency, but you don't see septations and it's at 4 millimeters, it's still abnormal. It needs to be followed. If you see a thickness of 4 millimeters and it has septations, it's abnormal, probably more of a cystic hygroma, and it needs to be followed. But both of them are normal and need to be followed. So ovarian mass is a corpus luteal cyst, most common ovarian mass seen in the first trimester of pregnancy. Corpus luteal cysts secrete progesterone. You know these. You went over them. They can be large. They can be up to 10 centimeters, and you'll see a cystic mass on one of the ovaries in pregnancy. Color flow imaging may demonstrate ring of increased vascularity around the corpus luteum. Usually they regress around 16 to 18 weeks gestation. You shouldn't see them anymore. That's what they look like. We also have fibroids that also occur with pregnancy. So a patient has a fibroid and gets pregnant, and they can coexist within the first trimester of pregnancy. But you do need to measure these and let them know, because depending on where they are located, they could interfere with the pregnancy. Rapid increase of the fibroid size may lead to necrosis of the myoma, and degenerating fibroid causes pain. But usually a myomectomy is avoided during pregnancy. Sonographically, fibroids may be hypoechoic, echogenic, isoechoic, typically cause deformity or displacement of the uterus, endometrium, or both. Here's a gestational sac, and here's a large fibroid in the lower uterine segment. Here's a pedunculated fibroid. And here's another one impinging on the gestational sac. All right, that's it for your first trimester complications. If you have any questions, let me know. Talk to you later. Bye.